Revenue cycle managers face a sudden convergence of regulatory pressure. Practices are losing revenue every month, even as patient volume remains completely steady. The Medicare Advantage program has reached a clear majority. Enrollment hit 34.4 million beneficiaries, representing 55% of all eligible Medicare beneficiaries. But alongside that growth is a significant documentation gap. Current data indicates that inadequate risk adjustment coding costs health plans an average of $3,000 per member every year. The operational paradox is striking. A patient's clinical profile stays exactly the same. Their chronic illnesses require the same level of care, yet the reimbursements attached to managing those patients are dropping. Capturing revenue in a Medicare Advantage model is entirely dependent on the structural accuracy of a practice's clinical documentation. The engine dictating those reimbursements is the risk adjustment factor, or RAF score. This single score translates a patient's health status into a monthly payment calculation. Every January 1st, that RAF score resets. A patient's chronic conditions do not carry forward automatically. If a diagnosis is not captured and submitted with the required clinical specificity each calendar year, it mathematically ceases to exist. This waterfall chart illustrates the leakage. For a practice managing 500 Medicare Advantage patients, missing documentation creates $1.5 million in annual revenue loss. That loss happens quietly, through simple coding omissions, before a federal auditor requests a single chart. Securing risk adjustment revenue requires a relentless, proactive annual recapture cycle. The standard for that documentation has shifted. The phase-in of CMS-HCC V28 is now complete, making it the operative standard for all risk score calculations as of January 2026. This visualization tracks the volume of that structural change. Over 2,000 previously valid diagnostic codes were deleted. The total number dropped, but the model expanded from 86 to 115 categories, requiring sharper diagnostic precision. CMS projected that this transition would reduce average Medicare Advantage risk scores by 3.12%, representing approximately $11 billion in net savings to the Medicare Trust Fund. While the national average drop is 3.12%, the impact on individual practices is often much higher. Because the code removals targeted common chronic conditions, many organizations have documented actual RAF score decreases of 5 to 8% on the same patient panels. In a recent analysis by IKS Health, a patient whose clinical profile generated $1,389 per month under version 24 drops to $836 under version 28, simply because the documentation failed to meet the new specificity standards. Visual similarity between diagnostic codes is a trap. Selecting a code that looks visually correct but lacks absolute V28 specificity yields $0. The most common point of failure happens inside the electronic health record. Practices are operating with legacy documentation templates that are still calibrated for the retired version 24 model. Looking at this side-by-side comparison, a provider might fill out the generic template on the left and assume the documentation is complete. However, it fails to trigger the specific diagnostic captures required by version 28, highlighted on the right. The mandatory baseline for clinical evidence is the MEET standard: monitoring, evaluating, assessing, and treating. Every submitted code must map backward to all four elements. Submitting an HCC code without verifying that the accompanying note meets the MEET standard creates significant legal exposure. A clinical note serves as a highly scrutinized financial exhibit, waiting for federal validation. This massive expansion of human auditors represents the scale of incoming federal reviews. Version 28's financial squeeze arrives alongside a massive escalation in federal auditing. This network map shows the geographic reality of risk adjustment data validation, or RADV audits. CMS has expanded its auditor workforce from 40 employees to 2,000, moving from 60 targeted plans to auditing all 550 eligible Medicare Advantage contracts annually. In 2023, CMS finalized a rule allowing audit findings to be extrapolated across an entire MA contract. Under extrapolation, failing the MEET standard on a small 200 chart sample mathematically projects that failure across the entire contract. A minor coding error can trigger large-scale recoupments of tens or hundreds of millions of dollars. Any unsupported diagnosis code is a live wire, capable of triggering catastrophic recoupments. Medicare risk adjustment under version 28 is a hyper-specialized discipline. Generalist medical coders are rarely equipped to navigate the required diagnostic mapping. The 2025 labor market carries a 12% nationwide coding talent gap, and 31% of the current workforce is actively considering leaving the profession. Finding an AAPC or AHIMA credentialed specialist capable of defending version 28 audits requires $55,000 to $75,000 in base salary alone. Practices fall into a destructive cycle. A specialized coder quits, backlogs build instantly, annual recapture deadlines are missed, and revenue vanishes while human resources spends months trying to hire a replacement. Relying on the legacy in-house staffing model to solve a structural compliance problem is economically asymmetric. High-performing Medicare Advantage practices are pivoting away from the pursuit of in-house hires. They are deploying dedicated, specialized outsourcing architectures. The Staffingly Medicare Risk Adjustment coding team is engineered specifically for this operational workflow. This interface highlights the technological differentiator. The Staffingly team works natively inside your existing EMR, whether that is Epic, Athena, or eClinicalWorks. The workflow includes strict oversight. Supervisors manage daily random sample chart audits to guarantee the clinical documentation can defend against RADV scrutiny. Native EMR integration, combined with oversight, neutralizes the liability and compliance risks of isolated third-party tools. Credentialed human specialists at Staffingly are augmented by an AI operational layer. It handles smart routing and surfaces documentation gaps before they escalate into compliance failures. This dashboard breaks down the unit economics. A fully managed version 28 compliant workflow is delivered for $399 per week per seat, directly contrasting the high overhead of an in-house hire. The operational include an error rate maintained strictly below 1%, zero vendor lock-in through a month-to-month contract, and a fully operational go-live deployment in exactly 14 days. In an era where version 28 mapping and RADV extrapolation can destroy margins overnight, practices must stop trying to hire their way out of a structural trap. It is time to